as you all know, yesterday the state came out with a advisory on how to set up this post-COVID clinics. Also, a technical paper on a short technical paper on the post-acute COVID-19 syndrome. Whatever data is available in our literature has been, it published that. But when we think about starting the post-COVID clinics, actually we were in two minds, because the post-COVID syndrome can manifest in two ways. It can manifest pulmonary embolism, so sometimes fibrosis. Some of them may be having non-specific symptoms like, say, lack of sleep and all those things, and we don't want people to be crowding into the post-COVID clinics and along with the bystanders, and these clinics may turn out to be epicenters of further infection when bystanders also come into the fray. So we place, and we need to turn up into these post-COVID clinics. I've accepted that the COVID-19 as a long COVID syndrome, then post-acute COVID-19 syndrome, and all those things. And the definition of the definition of post-acute COVID-19, a long COVID, is a multi-system disease, sometimes occurring even after a relatively mild acute illness. And post-acute COVID-19 is defined as manifestations extending beyond 3 weeks from the onset of first symptoms, and chronic COVID-19 as extending beyond 12 weeks. So recently, the UK symptom study, it was an app-based study. They said that around 10% of the patients will have symptoms after recovery from COVID, which persist for around, say, more than 21 days. And around 2% will have this chronic COVID-19 syndrome. And basically, the data shows that at 1 month post-recovery, around 14.5% of the patients will be having some symptoms. And at 2 months post-recovery, so around 5.5% will be exhibiting some symptoms. And at 3 months, around, say, 2.5% will be exhibiting some symptoms. And the pathophysiology of post-COVID syndrome has not been fully elucidated, but as of now, we know that the myriad multi-system manifestations is postulated to be persistent low-level inflammation or relapsing inflammation due to dysregulated immune responses. So this is from the WHO, the infodemic slides. We know that around 10 to 15% of cases can progress to severe disease, and 5% can become critically ill. So basically, what I wanted to convey is that in severe illness, the recovery may take up to 6 weeks. So an antigen positivity should not give us a false sense of security. So we should discharge the patients only when they are clinically stable. Antigen negativity by itself should not be taken as an indicator for discharging, to say that the patient is stable. We know that we have seen this slide many times, the extrapulmonary complications of COVID-19. So it is it's a viral bronchopneumonia with thromboinflammation. So you can have this thromboembolism or this thromboinflammation, which can affect any vascular pool. Can manifest as deep vein thrombosis. It can occur as pulmonary embolism or catheter-related thrombosis, mesenteric ischemia, acute coronary syndrome, can occur as stroke syndromes, etc. So these manifestations can occur during the convalescent phase as well. So we need to be pretty careful about that. And when we look at the cardiac manifestations, it can affect the heart muscle, which can lead to the cardiomyopathy, which can result in the post-COVID acute cardiac failure and can also result in cardiac arrhythmias. The endocrine manifestations, because the ACE2 as well as the serine protease 2 receptors are expressed by the pancreatic beta cells, can result in hyperglycemia and diabetic ketoacidosis. So even after discharge during the convalescent period, it may not be easy to achieve glycemic status with the pre-COVID doses of insulin. The dermatological manifestations we are pretty clear about, and the neurological manifestations like encephalitis, encephalopathy, the ADEM, the stroke syndromes can also occur during the convalescent phase. The renal manifestations, acute kidney injury, proteinuria, hematuria, can occur, and hepatitis and GI manifestations usually occur during the acute phase and not in the convalescent phase. So this is one multi-stage study from USA, which looked at the usual clinical manifestations observed in post-COVID syndrome. The most common being fatigability, followed by persistent cough or shortness of breath, loss of taste or smell, then headache, body aches, diarrhea, chest or abdominal pain, confusion, etc. So we do have a cohort of around, say, 500 healthcare workers in our hospital who are being prospectively followed up, and majority of them majority means around 10% of them do exhibit the same features, like say majority of them do have this fatigability. Especially we have observed that these females, they have this persistent anosmia as well. So this is another study, this post-discharge persistent symptoms. You can see that around 30% had impairment in the concentration. It's pretty important that we have observed in our healthcare workers as well. Then they have difficulty in falling asleep, or then sleep, REM, sleep disturbances are observed in around 30%. Memory loss, that is a short-term memory loss, is in around 34%. Exertional dyspnea in around 42%, and fatigability in 55%. So and some of them can even actually progress to chronic fatigability-like syndrome, akin to what is being observed in infectious mononucleosis. So basically, the post-COVID syndrome is a multi-system involvement. The cardiovascular system, they can present with palpitation, can develop myocarditis, cardiomyopathy, cardiac failure. Respiratory system, they can progress to lung fibrosis. It can lead to pulmonary artery hypertension and present with pulmonary embolism. The nervous system, they can manifest with prolonged anosmia, stroke syndromes, short-term memory loss, reduced attention span, confusion, poor quality of sleep, cognitive impairment, and cognitive blunting. This brain fogging is also a pretty important component, because some of our residents, after COVID, they find difficulty in concentration, and they regain their previous attention span, etc. only after, say, 1-2. And AC2 in dorsal root ganglion, that is what leads to this neuralgic pain. Okay, so and recently the BMJ did come out with an article saying that there are basically 4 post-COVID clinical syndromes. One is the classic post-critical illness syndrome, which we are all familiar with. Those patients who have spent a long time in the ICUs, when they come out, they may be having post-stress chronic fatigue syndrome like thing, decreased attention span, fatigue syndrome and all. Then the second one is the post-viral fatigue syndrome. Third is the long-lasting organ damage, which we all know, the bronchopneumonia, which can progress to this fibrosis, pulmonary artery hypertension, and things like that. Myocarditis, which can lead to cardiomyopathy. That is the lasting organ damage. And fourth is the fluctuating symptoms with slow recovery. So basically, the constellation of symptoms in acute post-COVID syndrome can be grouped into 4 categories. So this is just a video showing what happens to the lung damage which occurs in COVID-19. So these red areas are which the affected part during the this COVID bronchopneumonia, the acute phase, and after 6 weeks or 6 weeks or so, the entire lung has not recovered. There are areas of scarring or fibrosis, and after 12 weeks or so, there are areas of scarring or fibrosis, and these areas of fibrosis are responsible for exertional dyspnea, majority of the cases. And what is going to be the long-term effect? So as of now, we have only 8 months of experience with SARS-CoV-2, whereas we have enough and more experience with SARS-CoV-1, which actually showed that even after, say, 3.5 years following SARS infection, around 40% of the patients did have chronic fatigue symptoms. So we all know about the evidence of lingering heart damage in COVID-19. So patients may have subtle myocarditis, which can lead on to post-acute cardiac failure. So this is a German study which looked at around 100 patients who had recovered from COVID-19, and for which the cardiac MRI was performed. And it showed that the cardiac involvement was there in around 78%, with ongoing myocardial inflammation in around 60%. The most important aspect was this: the presence of chronic comorbidities or duration, severity of acute COVID-19 illness, and time since original diagnosis, etc., were not related to, did not correlate with these findings. So these findings do have clinical importance in the case of professional athletes. For example, we know that Djokovic got infected with the COVID-19. For example, if they want to resume their this competitive athletics and sports like activities, they actually should have a negative cardiac MRI, because their level of they go for their level of this strenuous exercises and all, and if your heart is not perfect, there is a chance that they can develop complications. So this is the algorithm from the state protocol. So we are basically focusing on the exertional dyspnea. So any patient who is complaining of exertional dyspnea in the convalescent period, so we need to rule out three things. One is it could be due to anemia, or it could be due to involvement of the respiratory system, or it could be due to involvement of the heart. So respiratory system means it could either be pulmonary fibrosis or it could be pulmonary thromboembolism. You can have segmental pulmonary embolism also, which can manifest as exertional dyspnea. Then if the respiratory cause has been ruled out, we need to look at the cardiac axis as well. So myocarditis, LV systolic and diastolic dysfunction, as well as cardiomyopathy can lead to exertional dyspnea. And how will we investigate these patients? Obviously, we need to do the hemogram. A CRP may give a clue to us the presence of ongoing inflammation. The D-dimer means if they're very much elevated, so we need to rule out pulmonary embolism. Then the PFT, X-ray chest, HRCT, echo as and when needed. D-dimer is elevated, and you don't have an alternative cause for this exertional dyspnea, you need to go for a CTPA. So if all the above investigations are normal, and if you can't find a reason for this exertional dyspnea, so in such a situation, so we need to consider cardiac MRI and nuclear scintigraphy. If you look at the German study, in those patients who had this cardiac MRI abnormalities, for majority of them, the echo was perfectly normal. So only subtle differences can be picked up only by cardiac MRI. So this is basically the approach to management of long COVID syndrome in post-COVID clinics. So what the state envisages is that we need to start these post-COVID clinics in all the PHCs, CHCs and FHCs. All the category C patients, that is the severe patients who are being discharged from designated COVID hospitals, should have their follow-up from these own hospitals. And we need to have a very good telemedicine linked referral system so that we can avoid crowding in the hospitals. And so what advice should we give to the patients who are being discharged, those patients who are this bronchopneumonia who are being discharged from the hospital? So the state guidelines do mention about the pulmonary rehabilitation, the breathing exercise that the patient should do so as to ensure the, the strengthening of the respiratory muscles, especially the diaphragmatic muscles. So what we are trying to convey is that we need to go for a graded exercise program along with pulmonary rehabilitation. Now, I'll take you to a case which presented to us around 3 weeks back. It's a 23-year-old male presented with fever and fatigability of 3 days duration, and the patient had pseudohepatorenal syndrome, myocarditis, blood pressure was 90/60, SpO2 was 95% on room air. Since the patient was coming from a cluster containment zone, and as of now, we can take the entire Kerala as a cluster containment zone. The COVID rapid antigen test as well as the PCR, both were done and were negative. So if you look at the investigations, patient had a total count of 25,000 with neutrophilia, thrombocytopenia, CRP was elevated, TROP-T was elevated, and BNB was very much elevated, suggestive of myocarditis. The tropical fever workup was done, everything was negative. The blood culture was sterile. Echo didn't reveal any vegetation. The D-dimer levels and ferritin and the CRP were very much elevated, and the procalcitonin levels are also elevated, and the interleukin-6 was also very much elevated. So at this point of time, a patient with the RAT and NAT, all these things negative. So coming with a probably a septic shock to the casualty. So what are the possibilities? So it could be a tropical fever syndrome, because in Kerala, so leptospirosis, wheel syndrome, all of this can present just like this. So it could be septic shock, but then we need to think about in a 23-year-old, what is the reason why this gentleman with no comorbidities has presented in septic shock. Infective endocarditis has to be ruled out, and we need to be aware of the concept of multi-inflammatory, multi-system inflammatory syndrome in adults. So basically, when we are post the peak, especially in UK, the MISC was described in children once the number of cases were so huge and they had sort of peaked. So the MISC was described in children, and almost all the pediatricians are very much aware of the clinical manifestations of MISC, which usually occurs maybe around 3 weeks after the occurrence of this COVID-19 infection. Likewise, MISC is defined up to 21 years, and now another inflammatory syndrome, hyperinflammatory syndrome, has been defined in adults, that is referred to as MISA. And this is actually the criteria for MISA. a severe illness requiring hospitalization in a person aged more than 21 years, a positive test result for current or previous SARS-CoV-2 infection. So it could be a RAT positivity or a PCR positivity during admission or in the previous 12 weeks. But the thing is that it is actually a hyperinflammatory response. So usually this antigen as well as PCR may be negative. So we can pick up this only by doing an antibody test, SARS-CoV-2 antibody test, which was done in this case, and IgG was found to be very much elevated. Then severe dysfunction or one or more of the extrapulmonary organ systems, the lab evidence of severe inflammation like elevated CRP, ferritin, D-dimer or IL-6, absence of severe respiratory illness. And this is actually one aspect which differentiate this MISA from a continuum of this COVID bronchopneumonia, because usually in COVID bronchopneumonia also you can have this multi-system involvement as well as a very much elevated the inflammatory markers, but then the lungs will be severely involved. Whereas in MISA, the lung won't be severely involved. The dyspnea is due to the presence of myocarditis. That is one point which will help in differentiating a SARS-CoV-2 infection cytokine storm versus a MISA-like presentation. And we need to, it is a diagnosis of exclusion. MISA is a diagnosis of exclusion. And we need to rule out other conditions like septic shock, tropical fever syndromes, infective endocarditis, and autoimmune conditions like SLE or vasculitis. And one thing we should keep in mind, approximately only around 70% of patients with MISA will have lab evidence of current or past COVID-19 infections. Okay, so in around 30% of cases, we may not be having an evidence of a recent a SARS-CoV-2 infection. So from history, also sometimes the infection which occurred around 3 weeks back could be an asymptomatic infection also. So the only way in which we can pick up this MISA is by considering it as a DD for septic shock. It can masquerade as septic shock. A couple of days back, we had a patient admitted in the surgery ICU. It was a 60-year-old female. So even in very much elderly patients also, we can have MISA-like presentation, present with acute abdomen, and patient was in shock, and all the inflammatory markers were elevated. She was coming from a containment zone. And then the CT, everything was negative. We could not identify a source for septic shock. And then this SARS-CoV-2 antibody was done, turned out to be positive. Patient was started on steroids. The treatment of MISA is similar to that of MISC, that is using high-dose steroids or IVIG if there is no response, and the patient responded to that. Okay, this is something which everyone is familiar with. That is the algorithm for means diagnosis of MISC in children. So all the pediatricians are familiar with MISC, and all the physicians also should be familiar with its equivalent in adults, which is referred to as MISA. And basically, in patients who are coming from containment zones, when we are in this phase of the pandemic, we should be aware of all the atypical manifestations: young multivessel or large vessel stroke, Kawasaki-like illness, multisystem inflammatory syndrome, hyperinflammatory shock, toxic shock syndrome, acute MI, GBS, viral encephalitis, ADEM, and all those things. In these cases also, we need to suspect SARS-CoV-2 infection, and we should know one thing. These patients can also, this like manifestations can occur in the convalescent phase as well. And this is actually the telemedicine platform which should be used for risk stratification to avoid crowding in our post-COVID clinics. So a post-COVID patient, so our focus should be on picking up the red flag signs. We cannot entertain all patients with this just mild fatigability, mild the body pain, lack of sleep, etc. in our post-COVID clinics. We don't want crowding to occur there. So we should be focusing on the red flag signs, that is the dyspnea, palpitation, chest pain, unilateral pedal edema, and syncope. And this post-COVID clinics will be in the PHC or FHC or CHC, and from there, after initial assessment, you can consult with our telemedicine with the consultants in designated COVID hospitals and in the clinics in the designated COVID hospitals, and if required, can be referred to those areas. For example, if you suspect that the patient is having exertional dyspnea due to a pulmonary cause or a cardiological cause, you may have to do other investigations which may not be available in a PHC or CHC. So you need to refer to higher centers, the secondary or the post-COVID clinics in the secondary care centers or the tertiary care centers. Now, what about the treatment of post-COVID syndrome, which is basically about pulmonary rehabilitation and graded exercises? If there is evidence of fibrosis in CT chest, we can use antifibrotics like pirfenidone or nintedanib. Then, and patients at the time of discharge itself, you need to handpick those patients who will require, say, prolonged anticoagulation for around, say, 3 weeks or so. That is those patients with the age above 75 with the D-dimer, which is 2 times elevated from the baseline, or improved VT score more than 4. Then cardiac failure, require treatment for cardiac failure. Chronic fatigue syndrome, we know that as of now, we don't have any proven strategies for chronic fatigue syndrome. We can try omega-3 fatty acids, vitamin D, vitamin E, etc. In case of neuralgic pains, we need to address that using gabapentin or pregabalin. Now, the first part, that is the post-COVID clinics and what to do about this acute post-COVID syndrome, has been dealt with. The second part is actually how to bring down the mortality. That is, to bring down the mortality, I'm not going to focus on the mortality reduction in hospitals per se, because all the hospitals are following the standard protocolized treatment. What we need to ensure is what Dr. Praveen did allude to, as well as did allude to in the introductory remarks. That is, some of the patients are reaching in a very late stage to the hospital. As per the state protocol, only the asymptomatic patients are supposed to be in home care. But unfortunately, even the category B patients are tending, and those with comorbidities are remaining in home quarantine or home isolation. And only when they are having dyspnea, they are coming to the hospitals. By that time, it may be a very late presentation. So basically, the prerequisites for home care, we all know it is the clinical eligibility criteria. That is, only the asymptomatic should be in home care. And the social eligibility criteria, there should be some person to look after them, etc. But in the current scenario, so this is not what is being followed. So when we look at the the August death analysis for the state of Kerala, so only around 0.8% of the patients who died didn't have any comorbidity. Rest of the patients have multiple comorbidities, like, say, hypertension, diabetes. 6% had cancer, coronary artery disease in 21.4%, etc. So only around 0.8% had no comorbidities. Okay, so this really brings one thing into focus. We are having patients with comorbidities in home isolation. That should not be the case. And we need to learn lessons from the people who have died. So this is the initial death audit of the 22 cases. And it showed that the majority of the people died in the above 60 age group, and the majority of the people who died were males, and majority of them did have comorbidities. And this is the data from our 1376 deaths, as majority of the deaths till now. And we can see that the majority, around 71% of the people who died in the state, were above the age of 60 years, and majority of them did have comorbidities. And if you look at the age split up, this is the age stratified case fatality rate. That is, less than 30 years in Kerala, the case fatality rate is 0.02. 31 to 60 years is around 0.18. 61 to 70 years is 1.29. 71 to 80 years, 2.32. More than 80 years is 3.83. You may argue that even in the people above 80 years of age, our case fatality rate is only 3.83. But we should always strive to better our case fatality rate. So what can we do to bring down the case fatality rate in people above 60 years of age? That should be what we should be discussing. Unfortunately, majority of them are still in home quarantine. So we need to ensure that they are taught to pick up the red flag signs at the earliest. And this is another thing, that is this is the reflection of the age versus mortality trends for Trivandrum. You can see that as the age goes up, the mortality rate is also going up. And this is another interesting slide, that people above 60 years getting infected is actually going up. As the epidemic has progressed, you can see that the bars are getting higher and higher, as well as the case fatality rate is also going up. So as the number of patients in the above 60 age group, more and more people get infected, the case fatality rate is also likely to go up. So here, what it really reflects is that our reverse quarantine has failed in certain instances, and the failure of our reverse quarantine strategy will reflect in our case fatality rate as well. So we need to pay more attention to our elderly population, as well as those with comorbidities. And this is one very important take-home message from our death audit. You can see that even in patients who have died, only around 60% had fever. So when we are looking at patients without fever in home quarantine, we'll think that they may be safe. So that is actually not the story. If a diabetic is remaining in home quarantine without fever, it may give a false sense of security to the person who is following up that patient. But what we need to understand is that only around 60% of the patients who died had fever. 40% of the patients without fever or the patients who died didn't have fever. Whereas fatigability was present in 82% and dyspnea was also present in 82%. So excessive fatigability, especially in those patients with chronic kidney disease, those patients with chronic liver disease, those patients with other comorbidities, along with this fever, we should also focus on excessive fatigability. So excessive fatigability in a patient who is in home quarantine, he should be hospitalized, no doubt about that. So these are our 3-level monitoring mechanisms. If this is working properly, then there is no need for an IEC. But unfortunately, we are having this category B as well as in certain instances category C patients turning up very late to our hospitals. So this is actually the state guidelines. So we need to have 3-level monitoring mechanism for the asymptomatic COVID-19 patients in home care. One is the daily telephonic monitoring by JPHN or the MO of the nearby hospital. Then the self-monitoring and reporting of symptoms. That is, red flag signs are there. They need to report to the person who is in charge of taking daily monitoring of their health, and finger pulse oximetry. So majority of them, at least a minority of them, do not have pulse oximetry at home, and that is a major challenge we are facing. So basically, this is the 3-level follow-up. That is the daily follow-up by the PHCMO or the JPHN. They will assess for fever or any red flag signs. If it is present, they will be shifted to the COVID hospital. Then self-assessment of symptoms. They have to observe for development of fever or red flag signs. If present, they have to inform DISHA and get admitted in hospitals. And pulse oximetry, daily pulse oximetry at least twice a day. SpO2 less than 94 or pulse rate more than 90, they need to be shifted to the hospital. So these are the red flag signs. This is very, very important. These red flag signs actually are meant for the patient who is in home quarantine as well as for the person who is following them up telephonically. The presence of altered sensorium, presence of dyspnea, chest pain, drowsiness, hemoptysis, excessive fatigability, syncope, and palpitation. The patient should not be in home quarantine. So whatever the patient says, we should have a mechanism to ensure that these patients are shifted to designated COVID hospitals. So basically, another aspect is that if a patient is in home quarantine, there will be people from the vulnerable categories, maybe their parents or their grandparents at home. And when we are monitoring the patient isolation, we need to monitor them also because they will also already be in the incubation period. So when we are asking about the health of the patient in isolation at home, we should inquire about the health of the patients in health of the vulnerable population also in that home. So when we are doing the telephonic monitoring, just ask about their health. And when we are looking for the red flag signs, just ask about the red flag signs in patients who have not been diagnosed with COVID-19 but are of the vulnerable group and high-risk contacts at home. It's pretty important. So this is actually the monitoring chart that the state is expecting the person who is monitoring to fill up. There is any symptoms, the pulse oximetry, psychological appraisal, social issues, etc. So thank you very much for the patient listening.
Thank you, Aravind. As usual, very excellent talk. Those who have queries can post in the chat box.
So sorry for the break in internet connectivity in between. Sorry. One question is, how early can we advise exercise? Actually, it has to be an individualized decision. So it has to be, the exercise has to be in a graded fashion. So those who have category C symptoms, who have been on ventilator, etc., we don't want to get them back to the routine exercise program all of a sudden. It has to be a graded program, and the way in which it has to be done is clearly explained in the state protocol.
Okay, next question.
Why unilateral edema is a risk factor? So unilateral edema is probably we need to rule out DVT. So a couple of weeks back, we had a patient, 85-year-old, who was discharged around 3 weeks back from another hospital, came with unilateral pedal edema. Patient had deep vein thrombosis and patient developed pulmonary embolism and expired. We had another patient who present with a dry gangrene of the foot. He was also an elderly person, was discharged around 2 weeks back, and the AK amputation had to be done. It was actually thrombus. Okay, so we need to be aware of the thromboinflammation. So even after discharge, this the ongoing inflammation can result in thrombotic complications. So one clinical sign we can pick up is the unilateral pedal edema. That's why we mentioned that.
Next question is when we can take a person as post-COVID case. Basically, the criteria when we can tell us as post-COVID.
Actually, is acute post-COVID is after 21 days and chronic COVID is after 3 months. So when we were discussing about it this a couple of days back, so there was an interesting question. When can we declare a patient as cured? Okay, that is very difficult to answer. In the setting of post-COVID, it's not possible actually. So, but then we need to understand one thing. This is not a very, very common thing, this post-COVID. So at 21 days, we are having around 10% with symptoms. And at 3 months, we are having around 2% with symptoms. And those patients who are likely to develop post-COVID complication or symptoms are those with multiple symptoms during admission. Usually, we are not seeing these post-COVID symptoms in those with mild symptoms or asymptomatic patients during hospitalization. Those with multiple symptoms, females and elderly. These are the group of patients who are likely to develop these post-COVID symptoms. And ICU stay, etc., and all we know is a definite risk factor for post-COVID symptoms.
Next is a question from Dr. Anju Kanmani. What is the ideal pain management medication for a post-COVID syndrome?
Actually, the medication aspect of post-COVID syndrome has not clearly been defined. So if the patient is having neuralgic pain, there is no point in giving NSAIDs. We need to give this pregabalin, gabapentin, etc. So regarding this neuralgic pain, even the pathophysiology for this neuralgic pain was only described around, say, 1 week back. So still early days for us. The patient is having neuralgic pain, definitely give gabapentin or pregabalin. If the patient is having polyarthritis or polyarthralgia, the usual NSAIDs or low-dose steroids will work.
What are the specific precautions to be taken in routine OP as well as post-COVID OP? PPE use
PPE use. Actually, that is one thing which we are really concerned about, because we are not expecting the patients, recovered patients to come alone. They will come with their bystanders, and bystanders may be infected. So the basic precautions we need to take. Definitely, a majority of us, even in the non-COVID pool, are using N95 mask or the triple layer mask, and we can use the face shield. And regarding the surgical gown, it is up to you. So basically, we need to be focusing on the face protection and hand hygiene. That will do.
When can a person resume routine work after COVID infection?
That actually depends. In a state, as per the state policy, it is for mild cases. 10th day we do the antigen testing. 7 days more limited isolation, and they can resume duty. So if they're having moderate or severe infection, 14 days plus 7 days, which is around 20 days. But then what we observed is that some of them means after getting discharged, when they start climbing stairs or when they wash their clothes in a squatting position, they will be having this exertional dyspnea. Then they will have to be evaluated. Some patients will be having this excessive fatigability when they return to work. So in such situations, the decision will have to be individualized.
Next is, if hypertension is well controlled, is the risk of moderate to severe disease is high?
If hypertension is well controlled, is the risk of moderate to severe disease high? That's the question. Okay, usually well-controlled hypertension, well-controlled diabetes, the outcome may not be very poor, but then we need to understand why hypertension, why obesity, why diabetes, why coronary vascular disease, etc. are associated with poor prognosis, because these are pro-inflammatory states. So in a pro-inflammatory state, the mechanism of organ damage in COVID is not only viral replication, it happens to be the dysregulated immune response also. So in patients with an existing pro-inflammatory state, the chance of a dysregulated immune response going out of hand is pretty high. That is why they progress to severe disease and modes.
Okay, Feluda paper test, are we doing it in Kerala?
No. As of now, we are not doing it. We are actually eagerly awaiting for Feluda test to come to Kerala.
Market lo vannitilla ennu thonnu
illa.
ഒരു കാര്യം പ്രവീണ, നമ്മുടെ IMA പ്രസിഡന്റ്, കഴക്കൂട്ടം പ്രസിഡന്റ് ഉണ്ട്, ഡോക്ടർ കവിത രാജി. She already had COVID illness. I think she can share her experience. She is already putting messages. Kavita ille, Kavita.
Madam has actually gone through the entire gamut of post-COVID manifestations.
Madam, I unmute ചെയ്തിട്ടുണ്ട്.
Unmute ചെയ്തോ? Okay.
Yes, കേൾക്കാം.
അരവിന്ദിനെ അറിയാം എന്റെ എല്ലാ പ്രശ്നങ്ങളും. ലൈക്ക് അരവിന്ദിന്റെ ഈ പോസ്റ്റ് കോവിഡ് ടോക്ക് കേട്ടപ്പോ I was thinking whether you ഇല്ലാത്തതൊന്നും ഇല്ലെന്ന് പറയേണ്ടി വരും. And like right now I ask you something, Aravind. Like recently എന്ന് വെച്ചാൽ ഒരു 2 months കഴിഞ്ഞപ്പോ തൊട്ട് എനിക്ക് ഇടയ്ക്കിടയ്ക്ക് ഒരു acute onset of tiredness വരും with drooping of my eyelids. എനിക്ക് കുറച്ചു നേരം കണ്ണ് പോലും തുറക്കാൻ പറ്റാത്ത പോലെ ഒരു acute tiredness. അത് കുറച്ചു നേരം ഒന്ന് എന്താ പറയാ എല്ലാത്തിൽ നിന്നും ഇങ്ങനെ ഡിറ്റാച്ച്ഡ് ആയി ഒന്ന് റെസ്റ്റ് എടുത്താൽ മാറും. So maybe it lasts for not more than 5 minutes. ഇങ്ങനത്തെ പല symptoms are like whatever you explained, no, you know, I had all those complications and it is a bad disease. And I'm really afraid that is it going to end or is it going to disturb me throughout my life? I don't know.
Madam, it will settle by itself, but then the time taken for it to settle, it will vary in different individuals. So this chronic fatigue syndrome like that, not to satisfy the criteria, 6 months of fatigability has to be there. But then what Madam is describing happens to be a subset of this chronic fatigue syndrome. That's a problem. And we know that it is a neurotropic disease. So because ACE2 receptors are present in the blood-brain barrier as well as in the brain. And now in that paper in the pain, they did say that not only the ACE2 receptor, neuropilin receptor can also be used by the virus to get into the brain. And this can lead to this brain fade as well as the brain fogging, this clouding of consciousness, etc. This can manifest in the chronic fatigue syndrome, and as what Madam is describing also, this. Madam, you had difficulty in concentrating and all those things, no, Madam?
Yes.
Yeah. Everything. Madam had everything. Yeah, because it's a neurotropic virus also. But then this won't last forever, Madam. So after some time, it will be normal. Especially in those patients who had been in the ICU, the post-COVID syndrome may persist for months.
And then one more question. Like I recently read that those who are having a high titer of antibodies, they are having these long COVID or chronic COVID syndrome. But you know, I don't have antibodies also. My antibody titer is too low, but I still have a long COVID. So
I don't have answer to the second question, but the first question, the thing is that it is actually a relapsing inflammation or a persisting inflammation. So the inflammation is stronger in those patients who mounted a very good immune response.
Okay. Aravind, do you advise doing antibody titer for this recovered patients?
Actually, no, the state advisory is to, because even if you are looking at the IgG, we cannot be sure that it is neutralizing antibody. Even if the neutralizing antibody is present, it has to be the neutralizing antibody against the receptor binding domain in the spike protein. So an IgG alone may give us a false sense of security. Instead of focusing on the antibody levels, we should be focusing on our universal masking and hand hygiene. And as of now, we are advising antibody tests only in 2 situations. One is, as you all know, prior to giving convalescent plasma, we need to look at the plasma IgG titer in the donor. And second one is to diagnose MASA or MISA.
Okay. Many of the doctors are actually doing this antibody titer and basically worrying their titer is low. That's why I asked.
I know. Actually, it's a cause of concern. If your IgG titer is not there despite having the disease, then whether you will get a reinfection, etc. Many people are worried.
The next is, when will be the post-COVID become non-infectious? Actually, that issue comes apart from post-COVID. When the patient becomes antigen negative, the issue comes because where to keep the patient in the COVID ward or non-COVID.
Yeah. So actually, so pretty tricky. Probably, I think that Kerala is the only state where we are insisting on a test to say that a patient is non-infectious. Rest of the places, they are going by a time-based discharge policy. That is mild symptoms. So the replication competent virus won't be present after 10 days. So they can be deemed as non-infectious and they can be discharged if they are clinically stable. In case of moderate or severe disease, it's around 15 to 20 days. So even without testing, you can discharge. Test is made mandatory only for immunocompromised patients, CKD patients, CLD, etc. They can have this replication competent viral shedding for a long period of time. So basically, we can say that majority of our category A patients, after 10 days, they are non-infectious. Category B and C, after say 15 days, B 15 days and C up to 20 days. They can be termed as non-infectious. Second part of the question is a bit more tricky. So can we actually take this patient from the COVID pool and put them in the non-COVID pools? Basically, as per the state policy as well as ICMR policy, even after this 10 days, for 7 more days, they are supposed to be in isolation at home now. So it's better to keep them in the COVID pool itself, because we know our non-COVID pool is actually the distance between the beds as of now is not say 1 meter, because we are having that much problem in the non-COVID pool also. Think about our gynec wards. Will we take a patient on the 11th day and put them among the other pregnant ladies? We won't do that. So there is no risk for us to maintain this patient in the COVID pool. So keep them in the COVID pool itself. Okay. They are not at risk of getting a reinfection on the 11th day or 12th day. So maintain them in the COVID pool.
Okay.
If they cannot be discharged.
Any observation of sudden tachycardia or dizziness with spontaneous resolution? Any description of autonomic involvement?
Definitely. Autonomic involvement we have observed in our patients. Even one of our residents, had this postural hypotension. We had to start fludrocortisone for him, and the mechanism is what has been described. That is, ACE2 receptor is present in the dorsal root ganglia. That can explain all the autonomic manifestations.
Next is, how long we should continue anticoagulants after discharge?
So anticoagulation, it is actually none of the guidelines do mention about the duration of anticoagulation to be given after discharge. What is the evidence says that if there is an evidence of thrombus, like say DVT or pulmonary embolism, definitely we need to continue for a prolonged period of time, maybe for 3 to 6 months. Those for whom we have started prophylactic enoxaparin or heparin, how long to continue depends on 3 factors. So one is if their D-dimer levels is twice that of the normal. So if it is more than 1, probably they will benefit from cerbroxaban or apixaban for 2 to 3 weeks. Or if their age is more than 75, or the VTE score is more than 4. So in these 3 indications, we can continue anticoagulation. Especially in high-risk individuals, it will be better to continue anticoagulation for around say 2 to 3 weeks, especially if the D-dimer levels is more than twice that of the upper limit of normal. And in pregnancy, you need to be careful, because the D-dimer cutoffs in pregnancy are entirely different from that of the general population. So in 3rd trimester of pregnancy, the D-dimer of 1.8 can be taken as normal. So, and we don't have any guidelines addressing anticoagulation pregnancy. So we do give anticoagulation, but it is not easy to titrate the dose of anticoagulation in pregnancy, because usually itself, because of pregnancy itself, we can have elevated D-dimer levels.
Thank you. Next is post-asymptomatic COVID patient for surgery. Do we do CECT and PTINR?
The PTINR is actually not necessary. The question is whether we will do a CT thorax prior to taking the patient for surgery. That depends on what sort of surgery it is. What we advise is that they should give clearance from the pulmonology department. So if they think that the patient is having exertional dyspnea, etc., and they merit a CT, only then a CT is taken. It is not mandatory to have CT. If the patient is perfectly normal, there is no need for a CT. If the patient is complaining of exertional dyspnea or exertional desaturation, probably a CT is warranted.
Another issue connected with this is when a patient is taken for a surgery post-COVID, they will usually do a screening RT-PCR, and then definitely it will come as positive.
A state advisory is in the making.
Okay. Any recommendation for warfarin if newer anticoagulants are not available?
Actually, the problem with the newer anticoagulants, the rivaroxaban, apixaban, all the evidence is for using those. That is the problem, but they are expensive. We don't have any suppose we have a proven case of pulmonary embolism or say DVT, definitely we can treat the patient with warfarin, because we have enough and more experience in treating DVT pulmonary embolism. Prophylactic anticoagulation means switching over from heparin to warfarin, continuing it for 3 weeks. It actually can be done, but there is no evidence. Only thing is the risk-versus benefit. It is slightly better for apixaban or rivaroxaban than warfarin. That's it.
Next one is if the patient had only a mild disease initially, is there a risk of organ-specific complications in the convalescent stage?
Actually, there was a beautiful paper in Nature. In around 42% patients with asymptomatic SARS-CoV-2 infection, when they did a CT, there was a mild ground glassing and a mild fibrosis was there even in asymptomatic patients. But we need not be worried about that. Actually, the post-COVID sequelae runs parallel with the symptomatology during the acute phase of the illness.
Most severe illness have 3 to 6 months for full recovery. Isn't it better to wait for 3 months before doing a battery of expensive investigations?
Actually, we don't want a battery of expensive investigations for all patients with post-COVID syndrome. That is why we are focusing on the red flag signs. If the patient is having exertional dyspnea at say 10 days after discharge, we can't wait for 3 months. Okay, so we have to focus on exertional dyspnea, we have to focus on palpitation, we have to focus on syncope, we have to focus on the pedal edema as well as the palpitation. If that is there, definitely don't wait for this 3 months and order a battery of tests and diagnose it, because the differentials we are considering is one is fibrosis, second is voluntary embolism which can't wait, third is the cardiac complications.
Do patients continue to be mildly asymptomatic in post-infection period, or post-COVID syndrome can come after an asymptomatic period?
We have discussed that.
Can we go antibody test for symptoms with no history of COVID?
Actually, there is no ICMR or state recommendation to do this antibody testing without an indication.
Are we seeing a higher number of myelitis post-COVID?
Actually, these demyelinating disorders are well described in post-COVID or along with COVID. We had around say 3 or 4 cases of say even Guillain-Barré syndrome associated with this COVID-19 is well described. Adam is also well described with COVID-19.
Next is from Dr. Naslin. What is the difference between antigen and RT-PCR and view of infectivity?
Okay, actually, thing is that we know RT-PCR, this prolonged RNA shedding, can go on up to 104 days. That is the longest recorded. Regarding antigen, we don't have that much of data. We are not expecting persistent antigen positivity. We do have people who have been positive for around 30 to 40 days as of now. But then usually antigen becomes negative very early in the disease course. So definitely, suppose on a practical front, suppose a patient who has recovered and say after maybe 2 months or so is presenting again with symptomatology suggestive of COVID-19. So if the antigen is positive, it is better to take as reinfection. But if PCR is positive, we can't say, because the RNA shedding can persist up to 4 months. Okay, so definitely antigen will become much earlier than the PCR. The RNA shedding is described only with PCR.
നമ്മൾ കുറച്ചൊരു prolonged antigen positivity കാണാറുണ്ടെന്ന് തോന്നുന്നു.
ഉണ്ട്. അതൊരു ആക്ച്വലി ചിലതില് അത് ട്രൂ പോസിറ്റിവിറ്റി തന്നെയാണ്, because in majority of the patients who are dying, the CKD patients, CLD patients, etc., the antigen is never becoming negative, and that is explainable also. It is that group where we are expecting viral clearance is not occurring because their antibody response is not very robust. But in other cases, even asymptomatic patients have tended to have this a prolonged antigen positivity for around 1 month, etc. And that's rare situations.
Can monitoring of saturation at home and acting accordingly prevent sudden cardiac death, especially if there is no dyspnea?
Actually, the answer.
Aravind connection boy.
Actually, the question was by pulse oximetry, can we predict a sudden cardiac death? Actually, we can't do that, because sudden cardiac death means probably it is due to a ventricular fibrillation or anything like that, or an acute coronary syndrome, where the hypoxia also is going to occur at the earliest. So we can't predict sudden cardiac death in a patient without any prior hypoxia using pulse oximetry.
Okay. How can we identify cytokine storm in home treatment cases?
Actually, the thing is, usually cytokine storm is likely to occur by say 8th day to 12th day. That is when the cytokine storm will occur. We need to look at the clinical features like excessive fatigability or the exertional dyspnea or fever. So if such things occur, and especially this fever we are not seeing in majority of our patients. So focus on excessive fatigability and exertional dyspnea. By that we can predict cytokine storm. But having said this, we need to understand that the state policy is not to allow any patient with category, with any comorbidities, even with mild symptoms in home quarantine. But unfortunately, that is not the ground reality. So we need to accept the ground reality. We need to accept that majority of our patients in category B are also in home quarantine. So when we are monitoring them, we need to focus not only on the fever, we need to ask them to, if there is no contraindications like say dilated cardiomyopathy or anything, we need to look at exertional desaturation. We need to ensure that all the patients with comorbidities in home quarantine do have an access to a pulse oximeter. Only then we'll be able to prevent this become happy hypoxia at the earliest and prevent progression to cytokine storm.
Okay. Okay. Thank you. Bennett sir, കേൾക്കാൻ പറ്റുന്നുണ്ടല്ലോ ആരെന്ന് പറയുന്നത്?
കേൾക്കാം. കുറച്ച് മഫ്ൾഡ് വോയിസ് ആണ്, പക്ഷെ കേൾക്കാം.
Okay. Okay. Next is which all tests are recommended in post-COVID clinics?
Post-COVID clinic, basically it is about the symptom screening. So we want to do tests only to rule out major complications like a pulmonary embolism, pulmonary fibrosis, pulmonary arterial hypertension, or the cardiac manifestations like a patient with subtle myocarditis or a post-acute cardiac failure. So the test will be, the hemogram should be done. So hemogram will give us a clue. Sometimes the patient may be having anemia, that may be the cause for an exertion dyspnea. So they correct that. So if there is no problem with the hemogram, then the other test will be, if you do have an access to X-ray test, do that. If you can do a CRP, pretty good. The pulmonary embolism has to be rolled out. In such situations, we have to do a D-dimer testing. Then this echo, the CTPA, etc., all based on the clinical situation. So all these things cannot be done in a BHC or the FSC level or a CSC level. So what we are expecting from them is to handpick those patients who require further evaluation and send them to the secondary and tertiary level post-COVID clinics.
Okay. Next is any risk of anticoagulant in cardiac patients already on clopidogrel and aspirin?
Basically, during the acute phase, there is no risk. Asking about the risk of bleeding. So what we do is, there is a score known as the Asper score, and based on that, we adjust the levels of heparin. Basically, it is a risk versus benefit thing, and based on the D-dimer level, we can actually risk stratify patients based on the D-dimer level. All patients with hypoxia definitely require anticoagulation. Then we check the D-dimer level. If the D-dimer is say between 500 and 1000, then probably a OD dosage of enoxaparin will be enough. If it is more than that, you'll have to go for a BD dosage. And if the patient is on dual antiplatelet, you take opinion of the cardiologist and think about stopping one antiplatelet and continuing with heparin.
Okay. Okay. Thank you. Next question is from a staff nurse in SAT hospital. I had chest pain during post-COVID period. Took ECG, showed normal. But still little chest discomfort is there. What I need to do? Is there a need of investigations?
Actually, a chest pain need not be a cardiac event or need not be related to a coronary problem. It could be costochondritis also. If the chest pain is persisting, you definitely come to the post-COVID clinic in medical college or come to the IDOPD. It requires evaluation. Probably it could be costochondritis also, which is well described in post-COVID syndrome.
Okay. Next, what are the frequent post-COVID symptoms in pediatric patients? Next,
pediatric patients, it will be better for you to answer.
Yes.
But then we are worried only about the MISC.
Yes.
MISC, because all the pediatricians are well aware of MISC. I think SAT, they had around 13-15 cases of MISC. So MISC is having a very good outcome because all the pediatricians are aware of MISC. But the problem with MISK is that majority of the physicians are not aware of MISK, and this MISK can masquerade as a septic shock. So that is a problem, sir. Only way in which you can pick up MISA during this stage of the pandemic is by considering MISA as one of the differentials of a septic shock. Only then you will be able to pick up a MISA.
Okay. Thank you. Next is how to identify reinfection and reactivation post-COVID.
Okay. The thing is, reinfection and reactivation, we cannot be differentiated without a genomic sequencing. So we need to do a genomic sequencing. So I think the person who asked this question should read the recent Lancet article describing how to differentiate between a deactivation and a reactivation versus a reinfection with a different strain. Because even in cases of deactivation or reactivation, the genomic sequence will be a bit different. Because if that the reactivation is occurring after say 3 months, by that time the de novo mutations would have occurred and some base pairs would have been altered. So there are ways in which they can find where there is a reactivation or where it is a reinfection. So we had one of our neurology residents who presented with reinfection, and our sample has been sent to CSIR for genomic sequencing. Without genomic sequencing, it is very difficult to say whether it is a reactivation or an infection with a new strain.
Do we have any data of the sequencing from India or Kerala with proven
reinfection?
Yeah.
The problem is that the best available resource on reinfection is by the European CDC. So they have a paper on reinfection. There actually they have described reinfection case reports from around six countries in the world, including India. That means that the literature about the reinfection in the world is so sparse. So this could be due to the lack of access to the first sample. So if you want to prove reinfection, the first infection which occurred maybe around 3 months back, that PCR should be available for genomic sequencing. In many centers, that is not the case. The first sample may not be available, or the quality of the first sample would have been deteriorated. So without genomic sequencing, we cannot say reinfection has occurred. The second thing is that the coronavirus, you know that we have around 4 human coronavirus, then SARS, MERS, and SARS-CoV-2. In the 4 coronavirus, reinfection is the rule rather than the exception, because you know the antibodies are persisting in human coronavirus infection for around 6 months to 1 year only. So SARS-CoV-2 need not be that much different. And the Lancet article says that the frequency of reinfection may be far more than that we are thinking, because some majority, around 50 to 60% infections are asymptomatic. So probably the first time you could have had an infection which were asymptomatic, and the second time it could have been a reinfection. When you are really diagnosed as having COVID-19, it could have been a reinfection, or it can occur the other way around also. You're having an infection, second time you're having an asymptomatic infection, no one is going to know about that. So we need not bother that much about reinfection, because the antibody-dependent enhancement is not a major mechanism in SARS-CoV-2 infection. So if there is no antibody-dependent enhancement, we need not fear it just like dengue. Secondary dengue, we are afraid because of antibody-dependent enhancement. Only thing is that, take-home message is that you should not be complacent. Even if you had infection once, you practice your universal masking, you practice your hand hygiene, all those stuff.
Okay, thank you. MISA will also show high procalcitonin, how to differentiate from bacterial sepsis.
Actually, it's very, very difficult, because I showed the procalcitonin value just to highlight that point. The procalcitonin levels were more than 100 in that case. And procalcitonin can also be an acute phase reactant. So just based on the procalcitonin, you cannot differentiate MISA from septic shock. So I will just take you through how we approach the recent 60-year-old female with MISA. She presented with acute abdomen. There's fever, abdominal pain, and she presented in hypotension. She was tachypneic, she had myocarditis, she had to be intubated, she had to be put on inotropic support. Now the question is, the lab values are suggestive of septic shock, no doubt about that. The counts were around 40,000 and around 98% neutrophils, and all the values were so much elevated, including procalcitonin. So definitely we'll think about a septic shock. So once we think about the septic shock, the next question is definitely going to be, what is the etiology of septic shock? That is it a bone and joint syndrome, skin and soft tissue, pulmonary syndrome, or CNS syndrome, genitourinary, gastrointestinal, or complicated intra-abdominal. So in this case, we will think about a complicated intra-abdominal infection, because patient presents with abdominal pain and vomiting. But abdomen was soft, the CT abdomen was also normal. So what the patient is in a really sick state. So there has to be something to explain this septic shock. No? So if you are not able to find a foci for the same, you need to consider MISA also, because without that, we will definitely diagnose the septic shock, pump broad spectrum antibiotics into the patient, and we will end up losing the patient also. So the only way in which we can differentiate MISA from septic shock probably will be not identifying a cause of sepsis and considering MISA as one of the DDs. If the PCR is positive or the antigen is positive, which is very unlikely, PCR may be positive, because the usual time at which the MISA is getting diagnosed is 25 days post the initial infection. So if there is no history of infection, probably the patient would have had an asymptomatic infection. After 25 days, MISA is occurring. So if their RNA shedding is there, the PCR may be positive. Otherwise, you need to look at the antibody level. That also is a problem. No? If the prevalence of the infection is so high in the community, even a septic shock may have an antibody positivity. So we need to look at the stage, the 6 criteria. If all the 6 criteria are fitting, then we can diagnose MISA. Otherwise, it's very difficult.
Okay.
Because the treatment is entirely opposite. You need to push high dose steroids into the patient with suspected septic shock. That is the problem.
Okay.
And the patient had a dramatic improvement with steroids.
Okay. Will the second infection be clinically more severe than the first?
Actually, it depends on what was the severity in the first infection. If the first infection was asymptomatic, second infection, whatever it be, will be more severe. No? So, out of the 6 case reports in the ECDC site, only 2 says that the second episode was severe. For our 2 cases of reinfection, both the times it was actually almost the same. So, there is no antibody-dependent enhancement. So, you need not worry about that. Don't worry that the second infection is going to end up in a ventilator, nothing like that.
Okay.
So, as of now, there is only 1 case report of a person who died because of a reinfection that was in Netherlands, and that patient had a bone marrow transplant, etc. And if it were in India and all, they would have died in the first instance itself. Since it was Netherlands, she died only in the second episode.
Okay. Next is there any study ongoing on long-term oral steroids in post-COVID to prevent progression to pulmonary fibrosis in patients with ground glass opacity alone in CT chest?
Actually, that is what we are doing because the low dose of steroids can actually prevent the progression to fibrosis. And also nintedanib also has an effect in fibrosis. So if there is fibrosis is demonstrable, definitely our pulmonologist will advise us to start nintedanib, which costs around, it's a tyrosine kinase inhibitor, which costs around 4,500 rupees per day, per month. Pirfenidone can also be used for established fibrosis. The only drug which can actually prevent progression to fibrosis is steroids, but then steroid is a double-edged sword. Our second case of reinfection, actually, she was on steroids for this, exertional desaturation. So, did steroids have any role in her losing her antibody? We are not very sure because when she presented the reinfection, her SARS-CoV-2 antibody was not detectable. But Kavita madam, even without steroids, it was not detectable because the literature shows that 30% of the patients who recover may not be having the neutralizing antibodies. IgG will be negative.
Okay.
And majority of the asymptomatics will lose the antibodies in the convalescent period.
So, will you add steroids if the patient is not responding to broad spectrum antibiotics, a suspected MISA patient?
Actually, MISA is not a very common thing. It's a very, very rare thing. So, what I am trying to say is that it's not that for all septic shock we should be adding steroids. I didn't mean to convey that message. So, MISA has to be a diagnosis or exclusion. So, if you are getting an isolate from blood, etc., please don't add a high dose of steroids. Maximum you should be adding is the stress dose of steroids like atroponetin 50 milligrams. If you are not having any diagnosis, think about MISA. This is a diagnosis exclusion. It's not only septic shock, which is a DD. In fact, the endocarditis is a DD. The tropical fever syndromes are DDs. Vasculitis, SLE, autoimmune conditions which flare up, all those things are DDs. Rule them out and think about MISA.
Last question. How far is life without mask and social distancing?
How far is life without?
Life without mask and social distancing.
Actually, it has become part of our life, masking and social distancing. I think that what is being observed in Europe, etc., they are having the second wave more severe. The second wave, the mortality is less, but the number of people getting infected are almost the same as the first wave. And what they are saying is that after a 3-month period, when the antibody titers wane, you are going to have the second wave. And USA is going through the third wave. Fortunately, we are just having our first wave because of the very good containment strategies, etc. We are able to delay the peak. Hopefully, before the second wave hits, an effective vaccine will come. Otherwise, I don't know how long it is going to be last like this. I think it will become endemic like H1N1.
Okay, thank you, Aravind. We will wind up the session now.
Thank you very much.
Thank you. Thank you. അപ്പം ഇന്നത്തെ സെഷൻ നമുക്ക് ഇവിടെ വെച്ച് അവസാനിപ്പിക്കാം. ഇന്ന് പങ്കെടുത്ത എല്ലാവർക്കും DMO തിരുവനന്തപുരത്തിന്റെ IMA IAPയുടെ പേരിൽ നന്ദി പറയുന്നു. ബെനറ്റ് സാർ, എന്തെങ്കിലും പറയാനുണ്ടോ? നമുക്ക് കുറെ കണക്ടിവിറ്റി ഇഷ്യൂസ് ഉണ്ടായിരുന്നു. നമുക്ക് മീറ്റിംഗ് അവസാനിപ്പിക്കാൻ തോന്നുന്നു. ബെനറ്റ് സാറിനെ കിട്ടുന്നില്ല. താങ്ക് യു.